what I want to talk to you a little bit about today, it's on, that's what it's written, but it is a sort of evolving story. When I began my career a few hours down the coast at Portland, Oregon, in deep brain stimulation, at that time, Kim Burchill was still doing micro-recording. He's evolved away from it now, as we were talking about on our way here. But I want to tell you a little bit about how it's been useful in our hands, in my hands. No significant disclosures related to this talk. So if we go back to the early days of specifically subthalamic nucleus stimulation, the days of Lim Benabid in Grenoble in France, and we're going back to the early 90s when he began to look at subthalamic nucleus, things were, by today's standards, somewhat primitive. They were still using ventriculography, not even CT, certainly not MRI. And the reason then for using micro-recording was because the best you had was what the atlas had told you was where the subthalamic nucleus was supposed to be. And actually, it was sort of no man's land. Nobody had ever been there before. In quite the opposite. You didn't go to the subthalamic nucleus because you were scared of touching the basal ganglia. And at that time, of course, everything was done awake and without medication. And these surgeries would actually take around 2 whole days to complete. So that makes it look very, very easy. Okay, I have made the target slightly larger, but we have made progress since then. And one of the major aspects of progress is imaging, of course. So yes, of course, we have lots of different protocols of MRI in quantum susceptible imaging, which is a post-processing thing, but we think we can see the subthalamic nucleus a whole lot better. And this sort of will lead into a debate, which I will relate to. Well, if we can see these things so well, why do we need to micro-record and validate our target in terms of electrophysiology? This is SWI imaging, and you can decide for yourself if you think you can see the subthalamic nucleus and what it is and where it is. And this is plain old T2, just a bit of Medtronic color added in for fun. Some of the aspects that have changed here related a little bit to the imaging is micro-recording. And I think that we have taken it a few steps forward, and I'll try and convince you of that today, why it is still a useful tool, certainly in our hands. And I hope we'll have enough time to talk about how the paradigm of awake surgery has also changed, even if you want to use micro-recording. So this is the debate. Is it necessary? As I said, if you've got imaging now, which is high resolution, do you need verification? And my take on this is, okay, yeah, I use micro-recording, and it's useful for me, I think. But the target is not an anatomical target. The target is a physiological target. And what you're doing with deep brain stimulation is actually manipulating circuits in a physiological way. So I believe that we need physiological verification of our targets. The work to correlate between physiology and imaging it will always falter because we do not have as high resolution imaging as we have high resolution recording. So Kim Burchill, many of you will know, he was my clinical mentor many, many years ago in this field. And the person who you might not recognize on the right-hand side is Chagai Bergman. And his fame started around in the 1980s. He's actually an MD PhD, and he worked with the DeLong group in Baltimore and was the person who described the ablation of the subthalamic nucleus in the non-human primate model way back in 1990. And it was his work that really gave Benabid the impetus to start implanting the subthalamic nucleus with electrodes. And some of that is written in this book, which Kim sort of pushed together to get out. But the truth is, it needs a second and third edition by now. So when I and Chagai began our collaboration together, Chagai is based at the Hebrew University, we had a few aims, which I think by and large we have realized. The first being, give me information that is relevant during the surgery that I can learn from my micro-recording, that I can understand quickly and it's relevant. is this somewhere inside my targets, specifically subthalamic nucleus, but not only, also the globus pallidus, which is more relevant than others. Yes, these things are very small, but we can be in different parts of the nuclei. Traditionally, everyone said, no, you can't do microrecording because it's complicated and it takes a long time. It's not complicated, and I'll show you that you can save a lot of time. And how did this information that we learned contribute to what we have? And FDA approved, I think, 2 weeks ago, closed loop deep brain stimulation. I think you'll see some of the work that helped sort of get there. And I hope we have time at the end to talk a little bit about the effect of sedative drugs on microrecording and the translational studies that brought us there. Okay, so what can, this is nothing new. You're going through white matter, which is sort of usually somewhere between the reticular shell of the thalamus and the internal capsule. And there's just a bit of background noise, but not really any firing. You might pick up an odd cell here or there, maybe the zone insert. And then suddenly there's this increase of the background and this wild firing. And you can detect that, you can pick it up very clearly, both visually and on the amplifier, and you can tell, and this will give you the span of your in and out, and then you know that you have at least electrophysiologically defined your target. So we took that information. I am not a mathematician, but what the root mean square of that electrical activity will give us is a sort of sum total of the electrical activity at the tip of the electrode. And you can plot that as a function of, here on the x-axis, EDT just means estimated distance to target, but it means I'm going along from left to right, i.e. down in my trajectory, and I am here in white matter. And then suddenly there's this huge burst of increased activity. That is the entry to our nucleus, and we carry on down. And you can see that prior to getting in, the sampling is at slightly larger distances. And then when you get in there, you want to get high definition recording, so step size goes down. And so that's our entry, that's our exit. And with that information, which you can get in real time, you can decide, I want to put my electrode at that time, certainly in the early days, somewhere about halfway down, 2/3 of the way down, it was considered that that top part of the nucleus, the dorsal part of the nucleus, was the motor area, and that's where you wanted to be. And that's where we would put our electrode, and that's just an imprint of a standard 3389 Medtronic electrode, each contact being 1.5 millimeters, separated by about 0.5 millimeters in between. But there was much more to the story, because the guy had known from his experimentation with the monkeys, with non-human primates, that the activity in the MPTP monkey wasn't just random firing. You could pick up cells that were firing in a very specific way and in a specific frequency. So one of our doctoral students took this information and did single cell sorting. And we could find groups of cells that would be firing both in the alpha, theta, and also primarily in the beta frequency. And to give an idea of what this really looks like, and this is not mine, it's from YouTube. You've got a bunch of metronomes firing. They are all firing at the same frequency. Okay, but there is no common input here. And now they get a common input. This is equivalent of depriving these metronomes of their dopamine. So this is now a Parkinsonian group of dopaminergic deprived cells in the skeletal pathway. And that's what happens to them. And this is a phenomenon of give them the dopamine back, and they will go back to firing at their own slightly independent rate. This is a phenomenon of physics described by the Dutch physicist called Huygens. Actually, he was lying in bed, sick, and he had two pendulums on the same beam. And he noticed that they were always in synchrony. When he got better, he took one away and realized that they both keep time, but they're not quite in sync. So now we can take that information and say, okay, where along my trajectory of recording do I see that oscillatory power, that oscillatory activity? And it turns out usually it's not all the way down, but as we would expect, it's certainly the dorsal part. And we can now create a spectrogram. The spectrogram will show me in red both how strong that signal is, but also now on the y-axis, I have the frequency of that oscillation, and most of it's going to be in the low and occasionally also in high beta frequency. And this is a famous beta oscillatory frequency that maybe some of you have heard about. The next thing we did was to do a retrospective review of a lot of recording spots. And the question here was, how long do I need to be in each spot of recording, in each point of recording, and how close do my recording points need to be in order to get maximum information that I just showed you in the previous slide? And it turned out that if you put this, if you put it into an automatic algorithm, that we only need to be in the spot about 2 seconds, but our step size needs to be relatively small. And with that, what happens is something like this. So the arrow is the electrode going down, goes into the nucleus, hits the end of the dorsolateral part, and then goes out of the nucleus. And we call this oscillatory area the dorsolateral oscillatory region. And of course, there is another part. In fact, there are two other parts of this nucleus primarily, the ventromedial non-oscillatory, which is made up of both associative cells associated with tracts that are associative and also limbic, and we'll discuss that in a minute as well. And here's what I wanted to show you. So if you use an automatic algorithm and you're not just sort of staring at these cells all day, you can take the recording time down by a very, very significant amount. So it's not anymore a time-limited issue. So the next thing to look at is to try and understand and characterize this oscillatory area. And what I have here, maybe it'll... So they're not perfectly in sync, I accept that. Clear again if necessary. On the left is the screen of the recording computer, and you can see there are two recordings, but only one is actually in the subthalamic nucleus. On the right, it might even be me moving the patient's hands and arm. So cells in the motor circuit will respond to both passive movement and active movement. And they primarily will respond to an acceleratory movement, not so much to a constant velocity movement. And if you use the fingers, which have many more joints associated with them, you're much more likely to pick up these cells. So you should be able to, I'll try and play it again, you should be able to hear that with those movements, there's a bit of a lag time in there. And sometimes if you don't pick them up with passive movements, you can request from the patient to squeeze your fingers, and then you can hear it, looking either for an increase in frequency or a decrease in frequency. And that way you know that those cells you're recording from right now are in the motor circuit or associated with the motor circuit. Why is that important? So what we did with that information was we took a whole bunch of patients that we recorded from the subthalamic nucleus, and what you can see on the x-axis really are big and large, smaller and larger subthalamic nuclei, all squeezed into the same x-axis. So if they were small or if they were large, the area in the darker gray is the over here or over here is the area that was the oscillatory area. And then we would look for these kinesthetic cells, these cells that would change their frequency of output with respect to movement. And as with every biological system, it's not a, sort of all yes or no, but the majority of the cells that would respond would be in this oscillatory area. So we're getting close to understanding that this is an area that serves the motor circuit. Another piece of research that we did at the same time was if we were doing 2 tracks down, so we would look to see if at any one time 2 electrode tips were in the oscillatory region. Were the outputs synchronized? And the answer to that was yes, but you wouldn't see synchronization if the tip of one or the other of the electrodes, or both of them, were in the non-oscillatory region. So these are clearly subserving 2 different circuits. And for me, this was the crucial finding, that if we looked at the outcome of the patients as a function of UPDRS, some of you will know, it stands for the Unified Parkinson's Disease Rating Scale. The third part is the motor part, and we tend to look at the delta, the change in that score, as a measure of success or motor success of the surgery. How much did that Parkinson's disability come down? The highest score is more disabled. The lowest score is healthy. And if you look at that delta as a function of how much or how long this oscillatory area was, we found a very, very close, almost linear correlation. So now I have a tool that intraoperatively can tell me how good my outcome is going to be. So, and that was published. Okay, I've so far just related to the subthalamic nucleus, but when you turn this tool, to the globus pallidus, the entry and exit are slightly more complicated. If you look at the one here on the right, though, I think it's pretty obvious that here we're going into a nucleus and then maybe coming out of it and then going in and coming out of it again. And this we interpret as to be the globus pallidus externa and then interna and then leaving that from below. And we can see most specifically in the GPI also beta frequency oscillation. So this isn't peculiar to the subthalamic nucleus, but it may well be something that we see much more in Parkinson's disease. Of course, we don't go sticking electrodes into healthy humans. That's just an aside to say that if you wiped out the pallidum in a previous era of pallidotomy, and then you think, well, maybe I can still help my patient by putting an electrode into the subthalamic nucleus, you're not going to find that oscillation, which really talks for the circuit between the subthalamic nucleus and the globus pallidus being one of the generators of this activity. And this was really, really interesting for me, actually. The model predicted that if you now find a target that is useful for another disease, in this case, the subthalamic nucleus, not the motor area, but the non-motor area in the disease OCD, which we know is a useful therapy for intractable OCD, you're going to find activity in an area that is not the motor area. This is now the limbic subthalamic nucleus, and we know that these OCD patients have multiple pathologies, some of which will clearly involve the limbic pathways. So just to summarize so far, we're talking about the area of the subthalamic nucleus that has pathological, exaggerated synchronous oscillations. If you put your electrode, your active electrode here, you probably get the best results of surgery. The overlapping evidence seems to show that this is the motor area of the subthalamic nucleus. There are many remaining questions. I'll relate a little bit to some of them because we know a bit more about them now. Is this just a function of individual disease? So somebody with 1 year of Parkinson's, you won't see that, but somebody with 10 years, you will. Is it a function of trajectory? Is it a function of both? And can we say anything today about the frequency of the oscillations? Because not everyone is at 10 hertz. Some is going to be at 20. Sometimes it's very high beta at 30. So question one, is it a function of trajectory? This is actually taken from a paper where they were looking at the difference between atlas-based targeting and MRI-based targeting. This was a group from Bristol in the UK, just to show that there are many ways to approach a subthalamic nucleus depending on how it looks on the imaging. We looked at that and found that trajectories that tend to come from more posteriorly and more laterally seem to get more of this oscillatory area in the track. And we published that in 2017, just a new paper out about a month ago, which is worth looking at because their analysis does not agree with us, but there is something there. And here, hopefully won't spend too long on this because we do not really understand the mechanism of how deep brain stimulation works. There's a very strong tradition here of epilepsy surgery, and in epilepsy surgery, the debate of whether we're talking about cells or tracts is a very well established debate that sometimes gets emotive and fiery. I think that we can take the same debate to deep brain stimulation for movement disorders, because we believe, or at least the physicists tell us, that stimulation seems to be affecting axons. But what I've just shown you now has been that we are using cellular activity to target our best target, to get the best location for our electrodes. So we have this cellular activity, which is a good targeting feature, but we think we're impacting axons. So I think that there's a lot to debate there, and it could be that the area that we are seeing cellular activity, those are the synapses and axons that we're trying to impact with our stimulation, but that's at the level of debate. So we've known about beta oscillations for an awfully long time, since Berger started his EEG recording. And it turns out that beta oscillations are not all bad. And so when do you call them bad? And we also know that you can train a monkey. We did this with Elon Vadia in the motor cortex lab. You can train a non-human primate to enhance beta activity, and you don't see any suddenly Parkinsonian activity. That's just in a reward punishment model of a monkey. And we can see normal monkeys. So not all beta is bad. That's just sort of to add into the mix of when you're trying to think about how to develop deep brain, closed loop deep brain stimulation. And the next part, of course, is how you differentiate between field potentials and spiking activity, because everything I've shown you so far is from microrecording. Those are recording the output of the cells, the spiking activity, the action potentials. Local field potentials almost certainly represent something altogether different. They're taken from usually much larger electrodes that probably represent a multi-synaptic input. And if you're going to call input and output the same thing, well, why do you have a subthalamic nucleus? So it has to be doing something. So one of the things that we looked at in the lab actually most recently was what is the relationship of these local field potentials, which we can record both intraoperatively, but now also postoperatively, either by externalized electrodes or more recently with the Percept IPG that Medtronic produces. And we can look at the relationship between this input and output. And in quite a lot of patients, it's the same, but in at least 1/3 of these patients, the frequency of the beta output seems to be lower. So the purpose of this synapse from the hyperdirect pathway to the output of the subthalamic nucleus seems to be a downward frequency shift. And it turns out also that this may be related to severity of disease and to success of surgery. So can you use beta oscillations? The answer is yes. We first showed this in the animal model. also in Hagai's lab. That was actually not using the subthalamic nucleus in the monkey, it was using the globus pallidus. And a lot of people have been working very hard over a long period of time. These are just some of them around the globe to develop these ideas and hardware. And this is the output of the tablet that comes with the Perceptor of Medtronic. I have nothing to do with Medtronic. They're just the only company right now that are doing this type of sensing. And if you've not seen this before, what really it's showing on the tablet is on the y-axis is the magnitude of the signal, and on the x-axis the frequency of the power. Now, in a normal person, what you would expect is this to be like you wouldn't have these peaks, and these peaks represent the local field potential. And in this particular case at 20 hertz, so that's well smack in the middle of your beta frequencies. And you can use these in multiple ways. Before you use them for the closed loop, you can choose which contact is going to exhibit that signal most strongly, and maybe you'll stop your programming with that signal to see if that gives you the best outcome. And of course, you can use a signal to drive your closed loop and say only when it reaches a certain amplitude should the stimulation be on. There are various different paradigms of closed loop. So that's where it got. Well, how are we doing for time? Okay, so the next part of the talk, I just want to go back to that slide and say, okay, so that's how micro-recording maybe has helped us learn where we should put our electrode. And I think that doing that, we've also been able to learn quite a lot about basal ganglia physiology. But the next question was, well, the world is going in the direction of sleep surgery because it's kind of for patients. Some patients are too anxious. Does it save time? Well, it depends really on your surgical workflow in the operating room. But for all of these reasons, these questions are being asked. And for me, given what I've just told you, so if a sleep surgery is going to be of benefit, then, and I want to continue using micro-recording. So what are aspects of micro-recording, if any, do I have to sacrifice in order to give the patient what they might want, which is a sleep surgery? When we first looked at this, clearly we were concerned that a lot of what we're used to picking up from our micro-recording might be affected by sedation or anesthesia, all these different parameters of what we're looking at cellular activity. And a literature search at that time, at any rate, first of all, there weren't that many studies, but also they were quite limited by lack of uniformity. What do you call a sedative? What do you call an anesthetic? What parameter it was looking at? And we attempted to go about this in a much more methodological way, using the tools that we'd already developed. But okay, so these were sort of, after a literature search, some of the things that really did shine out from that, that you're going to see a reduced firing rate. Well, you know, that doesn't come as really a surprise. Reduced amplitude. One thing of great interest, and we'll come back to this, was you would see an increase in burstiness of firing. And there would be a tend to a reduction of this dominant power of oscillation. And that for us was very significant because that's really what we wanted to look at. So this is one of the first studies we did, and was looking at propofol. And what you can see here at the top is the recording from the microelectrode, which is really background activity in the white matter. So you're not really seeing anything. We would get into the subthalamic nucleus. That's the second trace there. And you would see the classic background bursty firing of the subthalamic nucleus. And when we were happy that we'd found our target, we would stop. And we would start administering IV propofol until the patient was drowsy, and we had our ways of deciding how drowsy we needed the patient to be. We obviously didn't want them to get into any sort of respiratory distress, but the protocol defined how drowsy they would have to be, and that would be the trace during the propofol administration. And then you'd say, okay, we've seen what it does, stop the propofol and get back to the business of the day, which is finishing the surgery, and that's after the propofol. And once you've got your whole signal back, go ahead and continue the surgery. Well, take that information and then analyze it in the same way as we would analyze any recording. So what you can see at the beginning here of the trace is what was going on before we started the propofol. So we're inside the nucleus. Now the x-axis is a temporal axis, so we're talking minutes here. 0 from the start of the propofol. Here you can see the block at the top of the start of the propofol, when it finished, and then the rise back up to the full amplitude of the post-propofol experiment. And for me, the most interesting thing was what you can see here at the top on the right, because now this is a time-orientated spectrogram. And if before we could see here we could see the oscillatory power, again, in a beta frequency, it did not get lost during the administration of propofol. So we have a way of knowing where we want to put our electrode in the same way as we had in the awake patient, but here the patient was asleep with propofol sedation. And we repeated the same thing a few years later with remifentanil. And here you can see again, we get into the nucleus, we give the remifentanil and we stop it. And here the story was ever so slightly different. So you can see a very similar root mean square value on the x-axis. This is before we start the remifentanil. As we start the remifentanil, the signal intensity goes down, we stop it and it comes back. But look what happens to the spectrogram. So at the beginning, it looks okay, but it sort of drops off both in frequency and then completely disappears. So if I had to choose one sedative drug over another, right now my money is on propofol because I don't lose the information that I need. But we weren't happy with those results, so with the opportunity to go back and look at this in the monkey was staring us in the face. Two things happened. The first thing that happened was this. This was a recording from a patient who, routine surgery, and as many patients it happens, they're very anxious the night before. You've taken them off their medication and they don't sleep because they're anxious. And sleep in Parkinson patients isn't great anyway. So you put them on the table and you drill a hole in their head and suddenly they're all tired and they want to fall asleep even though they're awake. Something had happened to the signal which didn't seem the same as the signal before. Now, I can't show it to you because this is just a few seconds here, but this is not like it had been prior, okay? So the x-axis here is time, so I'm recording from left to right, and I looked around and the patient was asleep, which is fine, okay? I woke him up and then see what happens. So I am getting a good signal even when the patient is asleep. That was the message that I took away from this. It might be slightly different, but I'm still getting a good message. The second thing that happened was in a very unusual case of a young child with a strange dystonia as a result of some weird genetic disease. And his imaging showed that his globus pallidus, which is what we would tend to prefer to implant in dystonics, just had been destroyed by his degenerative process. So we did have a subthalamic nucleus there, and we decided to go ahead and implant him. And because he's a child and because he's dystonic with a dynamic component, that had to be done under general anesthetic. And this was before we'd done any of the experimentation. So he had general anesthesia, total intravenous anesthesia, probably with propofol, but I can't remember. But we were getting these beautiful, but literally very, very beautiful spectrograms that you can see at the bottom, meaning that even under this, quite heavy load of anesthetic, I can still get this type of signal. It wasn't something that we'd seen before. I just want to bring your attention to one small thing that, the frequency on the y-axis here shows that this oscillation is quite low, and that's what we had already seen in previous dystonics. So this was very much in keeping with what we'd learned about oscillation in dystonia. It's not really in the beta band, it's a much lower band. But the point was that they were there under all this anesthetic. So we went back to the lab and looked at lots of different aspects of recording while the monkey would be asleep. Just a word, I mean, these experiments, I didn't do them. Our doctoral students did them, and they're extremely difficult, not least because we want the monkey to have its natural sleep at nighttime. They play in their cage during the day, and at nighttime they're brought into the recording chamber. So my students had to invert their sleep-wake cycle, and for months on end they were sleeping during the day and in the lab at night, doing these experiments with the monkeys, and they would record and taking a lot of research into just a few slides here to summarize. So first of all, we realized the basal ganglia activity is very, very strongly associated with the sleep-wake cycle. And that shouldn't really come as a great surprise to us, because we know that sleep is very, very disturbed in diseases of the basal ganglia, among others, Parkinson's disease. And if we look at slow wave sleep, well, we could see that there was a decrease of firing rates, and REM sleep an increase in firing rates. Could we find a medication that might simulate these types of sleep? Because if we go 2 slides back, we saw that, we're going to get pretty good micro-recording with quite high fidelity, even if the patient is asleep. So which of the medications that we might use for sedation could best simulate normal sleep? Okay, and of course, once these experiments were done, you would make the monkey Parkinsonian with selective neurotoxin, MPTP. And this is some of the information that we get. So what you can see here are 5 different drugs. And on the left, these are the RMS signals, which really, again, show the totality of the electrical activity. What you see here on the time scale, on the x-axis, is prior to any administration of anything. So there would be about an hour here of just infusing saline, for example. Then you would give the medication, and then you would wait for it to wean off. So the RMS scores didn't really teach us anything very, very dramatic. Sometimes you would see, as we'd seen before, decline in amplitude, for example, here with propofol. But what was of real interest here were the spectrograms, because what we would see, and you can see this on the right of the screen, is that an oscillatory pattern emerged, and for the most part, this was downshifted with administration of the sedative drug, with one exception, and that exception is the one in the middle here. Sorry, the 4th one down. Look at that one, the ketamine, where the power of this output is at a much higher frequency than you would expect. And so that was the spiking activity, and you could see the same for field potentials. Again, look at the one with the ketamine. You can see that the power of the output is at a much higher frequency. So taking propofol and taking ketamine, we're still with the monkey, and these are just isolated cells. So 1 hour of baseline recording. The middle column is administration. You would see what you would expect to see with the propofol. There is a reduction of firing, and certainly amplitude of firing. But the ketamine, you're still seeing a really strong signal. Chagai Bergman calls this full gas in neutral. So the patient's asleep, certainly unaware, maybe even under general anesthetic, but the firing pattern, which is very reminiscent of REM sleep, is full gas, and you're going to get as much electrophysiological information as you need from that. And then again, weaning off a washout period over time, and that's the protocol that we developed to take our patients through if we wanted to do our surgery under anesthetic. So just to summarize again, that we could look at all of these drugs and determine what they would do both in terms of frequency and in the temporal domain. Ketamine would mimic REM sleep, as we just saw. Propofol would mimic slow wave sleep, which is what we saw previously in the patient that fell asleep. And what was really crucial for us here is that the time delay was short. So you want to record, but you want to get back to back to anesthetic and vice versa. And you don't have much time to play with because it's the patient on the table. So these were two drugs that really answered the criteria we were looking for. And again, this is before we went to the patient in the operating room. And you can see what happens here now. The lower trace is the firing rate. So baseline before propofol, and then ketamine administration, and then propofol, because here what we're doing is simulating a bilateral surgery. So you want to be able to give propofol while you're making the noise of drilling a hole in the head and doing whatever else we need to do before we start the recording. Ketamine when we want to be recording, and again, the second side, and then the washout period. And one of the first patients we did this with was a young girl with DYT1 dystonia. So again, what we're seeing here is what we suspect to be the GPE and GPI, a little bit different from the subthalamic nucleus, where we don't see two different groups of lamina inside the nucleus. Again, the low frequency oscillations. And this was a BIS recording to try and somehow not quantify, but at least see relative to before, relative to after, how deeply asleep the patient might be. And what these red arrows show are the start of and finish of ketamine for both sides in terms of the recording. And I think the timeline also shows you that this didn't take very long. So that was our proof of concept, and these have been published in the last couple of years. And to conclude, so basal ganglia activity strongly correlated with awake sleep stages and probably play a major role in sleep regulation. As I said, it shouldn't come as a big surprise to us, because we know that certainly for Parkinson patients, sleep is very disturbed and cut up. And we can look at how the physiology is changed by sedative drugs. Turns out in a fairly predictable way, and we could try that out on the MPTP model before taking it back to the operating room. So can we use sedative drugs for sleep surgery without sacrificing microrecording information? I would venture to suggest that yes, we can. No work like this is done by one person, and I probably have missed a few people out here, but some of these are doctoral students who've gone on to very successful postdoc careers. Some are anesthesiologists. Khagai is the head of the primate lab at the Hebrew University. Juan Leon is a fellow of mine who works now in Ecuador, and a few others. And this is Hadassah in Jerusalem. It's a constantly evolving building. What's missing from this fairly recent picture is we now have the light railway coming all the way to the entrance of the new building of the hospital. And of course, you're all extremely welcome to visit, spend time. Just let me know when you're coming. Thank you. She's taught me everything I know.
I bet she has. So, questions? Anything? Oh,
one, I obviously followed some of the work you've done with recording with anesthesia. Our anesthesiologists will not give Parkinsonian patients ketamine. They're very concerned about delirium and effects like that. Do you think, I mean, do you see for these short periods of time where you're interleaving propofol and ketamine, did you have any similar resistance to the use of ketamine for these patients? And then two, if you have been doing this, have you noticed any adverse effects of the use of that drug?
Are there any anesthesiologists in the room? So anesthesiologists are they are a cult to themselves, and they will be resistant to change, and they were resistant to these changes that we made in our protocol as well. But we have not seen any increased incidence of delirium. I think delirium after these surgeries comes really from, personally, I think they come from fluctuations of blood pressure under general anesthetic in a brain that is pretty sick. So I don't think that the ketamine had any impact on postoperative delirium or other problems. And I think the anesthesiologists realize this, and I do not face any antagonism from them since.
Very, very fascinating talk. You mentioned the OCD just on the side, but that basically you have the limbic system and also subthalamic nucleus. Do you think it's a similar mechanism though, that you get an increase in your beta power, or a totally different beast?
That frequency of that power was not in the beta frequency. It was somewhat lower. But I think anytime you see a focused, increased activity, and you can put an electrode there, you're going to see a change in the phenotype of that disease. The object of the exercise is to find that location. So we're still searching for it for depression, for example. We're still not sure where it is for Tourette, even though we've put electrodes in just about every part of the brain. My epilepsy colleagues here will know that we're now looking to find where the best locus for electrodes are for epilepsy. So that's the best answer I can give you. But I think the real answer is no, I don't know.
But the tool is that recording.
Yeah.
That's perfect.
If you were doing a case with propofol continuous at some level, would you be relying on interpreting the actual spiking pattern change, or exclusively focusing on the RMS metric for determining the entry?
Well, sort of, I relate to the RMS and the spiking pattern pretty much similarly, because, prior to going into a cell-rich nucleus, it's going to be pretty quiet. Once you're in there, certainly the subthalamic nucleus, it's going to be noisier. I think you can do these things under continuous propofol, and you will see a change. It's just that the change will be very, very attenuated.
Right.
So, you won't see this, you'll see something that is much more, and you won't know that you're in the right part of the nucleus. And as crazy as it sounds, because this thing is tiny, it's like 5 by 7 millimeters, I hope I've shown you that it really matters where you are inside the nucleus.
So follow-up question there, what is your configuration for STN in terms of how many microelectrodes you actually use to, placing 5 seems a little much, but
so I'm sort of
somewhere-
shooting myself in the foot with this answer, and we were discussing this a little bit on the way over, because I, like others, have honed down our imaging protocols so that I rarely find myself having to look in different places. For the most part, I will put down 1, possibly 2 microelectrodes, and what I'm really looking for is target verification, as opposed to hunting around with multiple tracks for my target. Occasionally, my imaging, for whatever reason, that day the magnet wasn't behaving itself and something, was non-homogeneous. And I do have to do more than 1 track, but it's pretty unusual. So, I'm not completely saying that imaging isn't important. It is. The better, higher resolution you can get off of your imaging, the more likely you are to have a successful location of electrode, but you still won't know about the physiology.